for discussion as well. So Dr. Toft, I'll just kind of follow along with you.
Okay, great. All right, so I think very relevant to this case and very relevant to everyday practice is guideline-directed medical therapy for HFrEF, heart failure with reduced ejection fraction is what we're going to talk about today. So these patients are everywhere, as you know, so especially for all of you nurse practitioner students, you're going to be dealing with heart failure all day, every day. And we've had some recent exciting developments in this field. So we're going to talk about level of evidence and class of recommendation so that you kind of know how strong are these guidelines and where did they come from. We're going to talk about how to actually implement these guidelines for your patients. And the hope is that this will actually lead all of us to change our clinical practice in accordance with the most recent guidelines. Next slide, please. Okay, so you may have seen this before, but I just want to remind you, because especially in cardiology, we are very big on classes of recommendations and level of evidence. So you'll hear that's a 1A, that's a 2B, and what does that mean? And so basically, the organizing bodies get experts together and they review all of the evidence that's out there and lend their recommendations. So recommendations come in classes 1, 2A, 2B, and 3. And they're color-coded here, and if you'll press next for me, Troy, the animation will pop up. It's pretty easy to remember. 1 means that you should do it, unless there's some reason not to, but you've got to basically, 1, you must do. 2A is good to do. 2B, you can consider it, you may, and class 3 is do not. So it's just kind of exactly as the colors indicate. So if it's a class 1 and you're not doing it, you're actually going to need to document why you're not doing it, because you can be held responsible for that. In the 2s, these are good things to consider, but you're not going to be held as accountable for it, but still that would be a high level of practice. And then if you're doing 3, you shouldn't be, so stop. And then our levels of evidence, that you can give a strong recommendation even without strong level of evidence. Level A means multiple randomized clinical trials, so that's the best. Level B means one randomized clinical trial or multiple non-randomized trials. So the evidence is pretty good, but it's not quite meeting that gold standard criteria. And then level C is just expert opinion. So you can have a class 1 level C recommendation where all the experts are saying you have to do this, even though we've never been able to fully study it properly. And so that's just good to keep in mind about where the evidence comes from and where the recommendations come from, as we've discussed through. Next slide, please. So for heart failure, things have been pretty stable for quite some time, but 2017 was a very exciting year when the guidelines did in fact change. And I think many of us are still catching up our practice to this because it was for so long. So beta blockers and then renin-angiotensin-aldosterone inhibition remain the cornerstones of treatment for heart failure with reduced ejection fraction. I'm just going to say heart failure from here on out, or systolic dysfunction. Those ones provide mortality benefit. Diuretics are the cornerstone of treatment for symptom management, but you may or may not know this. There is not any evidence that diuretics have a mortality benefit, but we do it because nobody likes having giant swollen legs or feeling like they're drowning. But I think important to know that the diuresis we're giving is not actually what's saving their lives. It's the other things. I tell my patients that they're beta blockers and then they're ACE, ARB, or ARNI. I say they're like vitamins for your heart, where you're not going to feel any different day to day, but they're making your heart stronger. Because I think people can be accustomed to the diuretic made me feel better, and now I can stop it because I feel better. I don't want them to treat these other medicines the same way. But then what was exciting in 2017 is that for the first time in a long time, we actually had new classes of drug to offer. So ARNI is the primary one. That's the angiotensin receptor neprilysin inhibitor, more commonly known as Entresto. That's the only one that's on the market right now, although I'm sure more will come. And then Ivabradine was the other new class of medication that was approved and put into the guidelines. So we're going to talk about both of those. And then the other things that this update helped us to remember is it's not just only about drugs. Sleep apnea got a good nod, so again, very relevant to our discussion today. And I think one that personally, as a cardiologist, iron often falls low on my list of priority. For those of you who are in primary practice, I think you think a lot about iron, which is fantastic, but we're reminded not to forget about those things. And then I think the key here is that we actually should be changing our practice based on these guidelines. And I confess that I am still catching up to this because the ARNI in terms of expense and pre-authorization, all that kind of stuff can be a little bit cumbersome. It's more cumbersome than what we're used to with ACEs and ARBs. But really we should be doing some changes. So let's go to the next slide and see what those are. So this is a slide telling us the mechanism of the ARNI or Entresto. So on the right-hand side in purple, we're reminded that in heart failure, and this does say HFpEF, but the same is true for HFrEF. It's just a better slide, so that's why I chose it. But in heart failure, the renin-angiotensin-aldosterone system gets revved up. And so the body basically thinks that it's volume depleted and thinks that it's hypotensive. And so as a result, it cranks up the RAAS system. And that leads to the things you see in the purple box. Vasoconstriction is the outcome of RAAS activation. Vasoconstriction, increased blood pressure, increased sympathetic tone, the myocardial fibrosis, more aldosterone floating around, ventricular hypertrophy. So within ARNI, there's valsartan. That's the same ARB that you're accustomed to using. And that valsartan blocks the angiotensin 1 receptor, so you have less of all the purple effects when you give an ARNI. So that we're accustomed to. What's new about ARNI is this of sacubitril, which is a neprilysin inhibitor. So on the green side of the screen, you can see that also what happens in heart failure as a compensatory mechanism, the natriuretic peptide system gets revved up. Now, unlike the RAS system, which is a maladaptive process, meaning it's a compensatory mechanism that actually makes things worse for the body, the natriuretic peptide system is a compensatory mechanism that does actually make things better. So we're accustomed to hearing about BNP, like we test that when people come to the hospital or we test it to see if they're in heart failure. Well, what that natriuretic peptide does is actually the things that you see in the green box. It decreases the blood pressure. It causes actually natriuresis or diuresis, so it makes people pee, decreases aldosterone, decreases sympathetic tone, decreases myocardial fibrosis. So what's a little confusing about this graph or this chart here is that the neprilysin inhibitor, it's actually inhibiting the breakdown of BNP. So you get more natriuretic peptide in the system. I don't like the way that they drew this, but again, it was the best one I could find. So when you give an ARNI, the net effect is less of the RAS system and more of the natriuretic peptide system. Does that make sense to everybody? Okay, so this drug was put into clinical trials, and we can go to the next slide, please, and had some great effects. And so as a result, these are the current recommendations for use of ARNI. Now, if you look at the top, I put this one on the top because it's the one that I have to really keep in mind. So class 1 and level of evidence B, that means that there was one randomized trial so far. And so what this says is if they have chronic symptomatic HFrEF, New York Heart Association 2 or 3, so they have to have some symptoms when they exert themselves. If they tolerate an ACE or an ARB, so these are your people, they've been on their lisinopril for 5 years doing great. We are supposed to replace that with an ARNI. So every patient who's coming in with heart failure, we should be evaluating whether I can switch them over because ARNI does seem to be superior in the clinical trial to ACE inhibition. So that is a big change. That's a lot of patients that we have to be considering this with. So we'll go through the indications. The next recommendation that you see basically says you can use ACEs, ARBs, or ARNIs, and that in combination with beta blockers and aldosterone reduce mortality. So that was something that was kind of already floating around. Now this recommendation to replace ACE and ARB with ARNI is superseding it. Now, if there's a reason why you can't, cost, other of the contraindications to ARNI, then you can still do ACE or ARB. But to technically be meeting that gold standard of best practice, we should be getting our patients onto ARNIs. So I'm still working on this in my own practice as well. Now, importantly, down on class 3 recommendations, so meaning don't do it, you can't double up. You will often and sometimes see people using ACEs and ARBs trying to get double bang for their buck. A lot of nephrologists will like to do that. You cannot double up ARNIs with ACE or ARB. You also, if they're on an ACE and you're going to switch them to an ARNI, you have to let it wash out 36 hours. We'll go over that. And then this is interesting. So as some of you probably are aware, ACE inhibitors that have caused angioedema, we try to get around that trick by giving them an ARB instead, because technically the ARB, because of the different metabolism and pathways, shouldn't cause angioedema, although we all get a little, right, about it. But you cannot give an ARNI to someone who's had a history of angioedema, so it's not quite as forgiving as the ARB. Okay, good. A question came through. What's the average cost of Entresto? You know, honestly, I don't know, but it's not generic. And I know that if you're trying to initiate it in the hospital, that's quite difficult. As an outpatient, it is better. But that's, I actually don't know off the top of my head what the out-of-pocket cost is for most patients.
Does anybody else on the call know what's the average cost of Entresto? Feel free to unmute yourselves or write in through the chat, please.
Or someone can look it up on GoodRx if they have it on their phone. Let's see what kind of coupons Walmart's running. Yeah, unfortunately, this is many years away from being generic. And so the insurance issue, it does have to enter your mind. Unlike ACEs and ARBs, which are all on the $4 list and generic and really easy. Okay, while someone's looking on GoodRx for that, let's move on to our next slide. So just a brief summary of the main randomized trial that got us ARNI. It's called Paradigm HF. It's a paradigm shift. That was a great name that they made. And so, okay, here we go. Robin got it for us. $280 for a 30-day supply. Easy, cheap, right? Everyone can afford that right now. There are probably patient assistance programs and all those kinds of things. I'm not as facile with them as I would like to be. So it is definitely a consideration here. Okay, and Dr. Bayun is telling us at the VA, hospitalists are, oh, how insulting. Hospitalists are not deemed sufficiently qualified to prescribe Entresto and has to go through cardiology, and then getting that non-formulary approved takes an act of Congress. Yeah, I think, unfortunately, VA is going to take a while to catch up to this, even though probably all your patients qualify, Dr. Bayun. Yeah, I think the inpatient initiation is kind of the next step, but that is quite difficult to accomplish because of some of these reasons. And hospitals are not keen on paying for this medication when the trial was only done in the outpatient setting. But stay tuned, I'm sure we'll get there eventually. So here's what the trial was. These were stable outpatients, and it was ARNI versus enalapril. Those were the two arms. What they were looking at in terms of endpoints was cardiovascular mortality plus heart failure hospitalization. So if you guys are aware of this, in trials, they often do this trick where they make a combined endpoint because the hope is that it will be a positive trial then. And if they're not certain they're going to get a mortality benefit, they'll try to lump something else in with it. So we always have to be a little bit suspicious about combined endpoints. That said, this trial just blows everything out of the water. In addition to that, I think that both cardiovascular mortality and heart failure hospitalization are very worthwhile goals to reduce. When we think about the burden of heart failure, it's the #1 diagnosis for entering a hospital. It costs one of the costs in terms of healthcare dollars in this country. So reducing that is also worthwhile. So I accept their combined endpoint here. But then they also separated them out and looked separately at cardiovascular mortality, heart failure hospitalization on its own, and then all-cause mortality. And basically, ARNI was just winning so amazingly that they stopped due to a very clear benefit. All of those endpoints saw a 20% reduction in the group with ARNI, a 20% relative reduction between the two groups. To put that into that's a huge difference between groups, a very huge difference. So this really is a powerful medicine. I put on here number needed to treat was 21 patients. So in order to prevent one mortality or one heart failure hospitalization, you need to treat 21 people. That, I don't know if that sounds high or low to you, but that's essentially the same as the number needed to treat for statin. And we all believe in statins and prescribe them, right? So this is basically on that same level of potency. And for me, that's a very powerful reason why I want to be trying to get my patients onto this. But there's always a trade-off. And the trade-off here was more hypotension and rising creatinine in the ARNI group. So we'll go to the next slide and dive into that a little. Okay. So it's always important to see who was included in the trial because it wasn't everyone. And we're going to do an exercise at the end of this where we go through some patients to decide together if they would be eligible for ARNI based on these criteria. So EF of less than 35%. So that's already thinking about Suzette's patient here, right? Because he wasn't quite there. And they have to be New York Heart Association class 2 to 3. That's the majority of your patients. As a reminder, New York Heart Association class 1 means no symptoms. You probably just didn't ask hard enough if they really have no symptoms, right? I had a guy, he was 30 years old, EF of 10%, and he power lifted at the gym, which I stopped, but he was really asymptomatic. But most people are going to be 2 to 3. Class 4 is symptoms at rest. Those are end stage patients. So this is going to catch most of your heart failure patients as long as their EF is 35 or less. Another kicker is that their GFR had to be above 30 and potassium below 5 because of this, the effect on the RAAS system. So again, Suzette's patient, I think, is out based on that. Systolic blood pressure at enrollment had to be above 95 because this gives you a much more powerful blood pressure reduction than your ACE inhibitor or your ARB alone. So I think Jenny was asking about ARNI, which I wish that we could get Suzette's patient to qualify for because it does give you more potent vasodilation. So if they're on 10 milligrams of lisinopril and you're going to switch them over to ARNI, you should expect that you're going to get about 10 more points systolic reduction in blood pressure than what you got with your ACE inhibitor, depending on the dose, of course. But then for the patients in this trial, for the patients for whom you're going to initiate ARNI, either they need to be on a stable dose of ACE and ARB and you're just switching them, or you can now, based on that new guideline, you can initiate ARNI as fresh therapy for the patients. It used to be they need to have been on an ACE or an ARB and tolerated it, and now we can switch them. But fresh therapy is reasonable. So when you're starting it, there are some tricks of the trade here. If they're on an ACE inhibitor, you stop it and you have to wait at least 36 hours to let it wash out of the system. I think 2 days is reasonable. And then you're going to start them at a low dose. If they're on an ARB, because there's an ARB in the ARNI, you don't have to wait for a washout period. You can do a direct switch. If they're not on either one, you would want to start them at a low dose. And then for everyone, you want to up titrate that medication until you don't have any more blood pressure room, or if you see rise in creatinine or potassium. But really, blood pressure is probably going to be your rate limiting step here because it is very potent vasodilator. And then this is not written into anybody's guidelines, but personally, I like to check the BNP at about 1 week out to see what their kidney function is doing. And I think while I'm getting used to using this medication, I will probably check a BNP when I up titrate with the first up titration. For me personally, with ACEs or ARBs, once I have them on a dose and they've shown me that their kidney function is fine, I don't recheck a BNP every time I up titrate because the relative difference is going to be little. I'm still getting used to ARNI, and so I will probably check BNPs more frequently until I have a sense of what it tends to do at different doses and if it changes creatinine or potassium very often. So that can also be a barrier to starting this, right? If patients don't go and get their labs drawn, it can be tricky. Okay, great. Questions on that initiation?
I have a quick question about eligibility. So I know there's, all the points that you went over with the EF and the GFR and everything. The last bullet point stating either on a stable dose of the ACE or ARB or fresh therapy. So if you're already on a stable dose of an ACE or ARB, do you still have to meet all the first 3 bullet points? Like, for example, if you had like a slightly low EF at 30, let's say, but you're on a stable dose of an ACE or ARB and you're doing really well, would that do you have to meet all the eligibility, or could you have, be on a stable dose and then not meet some of the other?
Sure. Yeah, great. And this might be a great question. It might be because of how I wrote it. The main inclusion part is that your EF has to be less than 35. So the patient you described, EF of 30 on a stable dose of ACE or ARB, yes, switch them, as long as kidneys, potassium, and blood pressure allow. So the middle 2 bullet points are just saying you have to make sure their kidneys, potassium, and blood pressure have room for this medicine. Does that make a little more sense?
Yes, thank you.
Yeah. And so in fact, the patient you described absolutely should be switched. That is now the guideline. They should be switched over to the ARNI provided they can afford it. Okay, fantastic. Let's go to the next slide. Great question. So again, just in practice, beware of hypotension. So my friends who are heart failure specialists, they usually want a systolic pressure of at least on your ACE or ARB before they start this, because it is going to give you a nice drop in your blood pressure. You need to be very careful about volume depletion and the elderly. I think many of you are probably aware of the combination effect. So when you have a diuretic plus a calcium channel blocker, for example, and they're an old person with stiff vessels, that's a great way to have them have a little bit of syncope or pre-syncope. And this is the same thing. You have volume depletion because of that natriuretic peptide, and you're having less vasoconstriction because of that ARB. And so if you have someone who already tends to be volume depleted or the elderly, definitely start low and be cautious about this because it can exacerbate both of those things. And then, as I mentioned, if they've had any history of angioedema, stay far, far away. And then no combination therapy, no double bang for our buck. Okay, next slide. So any other questions about ARNI before I move on to this other class of medicine, which is Ivabradine? I think ARNI is really the game changer, and so it's the main one that we wanted to think about. All right, great. No questions that I see, so let's move on to Ivabradine. So in practicality, ARNI use skyrocketed. Like, I wish I would have invested in that company. Ivabradine is, because we don't have a mortality indication, it's not being put into practice quite as much, but there is good evidence and a 2A recommendation. So let's go over what Ivabradine does. If you remember to when you learned about action potentials, stretching our brains today, there is something called the funny current. The funny current is the thing that slowly depolarizes pacemaker cells and allows the pacemaker cell to be depolarizing spontaneously. Ivabradine inhibits that funny current, and so it slows down the intrinsic pacemaker cells of the heart. And so the study for Ivabradine was looking at heart failure hospitalization, and it worked, but we don't have the same mortality benefit that we saw for ARNI. So we have a 2A recommendation, level B, so from the one trial, for basically similar patients, chronic heart failure, EF less than 35%. They're already on good medicines, including a max dose beta blocker. So you've already maximized, for example, your patient is at carvedilol 25 BID, that is the maximum dose, fantastic beta blocker. If you still have room in their heart rate is still above 70 at rest, you can give them Ivabradine. And that does reduce heart failure hospitalizations, which again, is a very worthwhile goal. I think it's just been slower to get into practice because it's not often that you really reach the peak of beta blocker therapy and still have heart rate room. I think, at least in my practice, I'm more often having to cautiously peel back beta blockers, and because we don't have the same mortality benefit, but still a great new drug to be considered. And I don't know the cost for this one either because I actually I've never prescribed it yet. Questions about Ivabradine? Okay. How did the manufacturer come up with the dosage ratio? The dosage ratio for ARNI, is that what you're talking about, Dr. Bayun? Oh yeah, for Entresto. Yeah, I don't know the details of how they came up with those dosages because it is in combination. And so as you titrate, you don't have flexibility in the two arms. You have to kind of go in their things. But that's how, we're kind of limited by how the doses were chosen and by what was studied, but I don't know the details of how that was chosen. I will say one of the criticisms of the study for Entresto is that the dose of enalapril was much lower than what most people are using in practice. The dose of enalapril was, I think, 10 milligrams twice a day. And, I think lisinopril is used much more commonly and also at much higher doses. So that was a criticism, but not enough to overcome powerful reduction in mortality that we saw. Great question. Okay, so that's Ivabradine for you. Let's move on to some of our other recommendations here. So here's what I'm calling miscellaneous. So our first one is about iron deficiency. So a lot of people are checking iron panels on these patients. And it turns out that if you have ferritin less than 100, or low transferrin plus borderline ferritin as written there, you can consider IV iron replacement gives better quality of life and better functional status. So no mortality benefit here, hospitalization. This is a 2B, so that means you can do it if you want to. But I think a useful thing, particularly because a lot of primary care providers are looking a lot of iron deficiency, so you can keep in the back of your mind that you might be benefiting their heart failure as well. However, don't be tempted to think about EPO or any of those other agents. Those are not good, so don't do that. Just IV iron if you're going to do something here. I added in this, there are several other recommendations, but I wanted to highlight this third one, nutritional supplements. I don't know about you, but I get asked about nutritional supplements all the time. Coenzyme Q, all different, that people bring me in things I've never even heard of. I'm buying this special vitamin off the internet. And so I try to, listen respectfully, but there is no evidence for routine nutritional supplementation if someone's deficient. If they're vitamin D deficient, yes, treat their vitamin D deficiency. But these advertisements for heart start vitamin, not recommended. And then getting to really Suzette's patient she presented to us today, we really want to be aggressive about blood pressure management in our patients with HFrEF. And so the goal that was, again, redone from more recent data is a systolic less than 130. So we really want to be aggressively treating blood pressure and not just our neurohormonal axis that we've been discussing. Next slide, please. So here is the kind of new algorithm. And it might look complicated, but it's actually not bad at all. So you start over on step 1. Okay, we've established that they have HFrEF, looking at their volume status, and we start. And here's where we start. We start with beta blockers, ACE or ARB, traditionally, and diuretics. But what we then do is move over into step 2 and we tweak that therapy. So we've started them on some good therapies, and now we assess, okay, do they still have symptoms? And if they still have symptoms, I am New York Heart Association class 2 to 4, and they're already on RAS plus beta blockers, I can put them on aldosterone antagonists, so spironolactone or eplerenone. This has very good evidence. I think it gets forgotten a lot of the time, but very important to get people onto that spironolactone. Then we can look and say, oh, actually, they qualify for ARNI. And so I can switch them over to an ARNI. And that's also a class 1 recommendation. And as I mentioned a bit with Suzette, New York Heart in class 3 to 4 in Black patients, there's evidence for hydralazine plus nitrates. So we often try to get those patients on these medications, sometimes in lieu of ACE or ARB, especially if there's renal dysfunction, but sometimes we start with it there. But this is a very useful combination, particularly in Black patients, particularly if into kidney problems. Because as you've seen, we're now talking about 3 different classes of medications that it can all impact creatinine and potassium. So this is a dangerous game we play. And then there's 2 device therapies in there, which I'm not going to cover today. And then at the bottom is thinking about Ivabradine, but it's the one that's in yellow. So our green are the far more important recommendations. Questions about this? I think important to point out under step 3, choices are not mutually exclusive and no order is inferred. So this is a bit challenging to decide what you want to do next. I think you can think about spironolactone and ARNI in similar ways, which is I want someone with reasonable renal function, potassium's not been a problem, and they're compliant to come and get their labs checked. So even though we are allowed to initiate spironolactone in the hospital, and in fact, in some instances we are supposed to, I often make my patients prove that they're going to show up to at least 1 clinic visit before I initiate it. That's because when spironolactone was approved, the rate of hospitalizations and deaths for hyperkalemia went up by 7 times, 7-fold, because of all the hyperkalemia. I think we're better about it now, but I'm curious to see what's going to happen with ARNI. Going to be more hypotension issues that we might see, but just good things to keep in mind. Okay, next slide, please. I want to get to our little scenarios. Okay, so I've made 4 patients for us. I want to point out that they're pretty similar. The patient 1 and 2 are both 65-year-old women with an EF of 30. Patients 3 and 4 are 9-year-old men with an EF of 30. So at face value, all of these people are potential candidates for an ARNI. So we're just talking about ARNI for these patients, okay? So if you'll go to the next slide, we're going to describe them a little more and see how their descriptors change things. And what I want each of you to be thinking is, which of these patients is eligible for ARNI? And let's say they all have amazing insurance, and so they can all afford it. So patient 1, newly diagnosed in the hospital 4 weeks ago with this EF of 30%, short of breath around the house, but with diuresis that improved to 1 flight of stairs, but still short of breath. Blood pressure is currently 132/88, heart rate 65, creatinine 1.8, potassium 4.2. Was sent home on carvedilol and furosemide. For some reason, no ACE or ARB was added. So that's patient number 1. So think in your mind and make a little tally, yes or no to ARNI for this one. Patient number 2, same little one-liner, but you've been following this person for 6 months. Hikes 2 miles per day. I'm out here in the Sierra Nevada, so a lot of my patients like to and does not get short of breath with 2-mile hike. And it's a decent clip. Blood pressure is 90, heart rate of 80, creatinine 1.2, potassium has been 5.3. And this patient is just on metoprolol Suxin. Okay. Patient 3, oh, I changed it on this slide. Pardon for the confusion. I made this one an 89-year-old patient, so pay attention. EF of 30, currently in the hospital. Has very limited mobility, but gets short of breath even when trying to dress himself. Blood pressure is 110/, heart rate is 100, creatinine is 2.2, potassium is 3. Currently in the hospital on furosemide, potassium replacement, and dobutamine. And then patient 4, 79-year-old man, EF of 30. You've been following in clinic for 3 years. He has a pretty big hill to go to his mailbox and does get shorter, does that. Had cabbage 3 years ago, and that didn't really change his functional status. Blood pressure is 127/90, heart rate 55, creatinine 1.7, potassium 4.8, currently on carvedilol, lisinopril, furosemide, and spironolactone. Okay, so let's have people share. Why don't you share on the chat just the numbers for which patients you would think about prescribing ARNI to? And I'll get some answers before we move to the next screen. Okay. All right, we're getting some votes coming in.
Yep, a couple that have said 1 and 4.
Okay. Lots of votes for 1 and 4. Definitely patient 1. All right, good. I like those votes. Let's go to the next slide and see kind of what we are thinking here. Okay, so I've put in red contraindications or reasons why someone wouldn't qualify for ARNI. So great job. You guys all picked that up, that 2 and 3 were not good ideas. So patient 2, if someone would sum up, what are the reasons to not put patient 2? I've put them in red, but somebody want to sum it up for me on chat or out loud? All right, some time, I'll just do it. This guy is class 1 symptoms. He's doing fantastic. His blood pressure is a little bit, potassium's a little bit high, and he has not been tried on ACE and ARB. So this guy, just leave him alone. He's actually doing fine, and we don't want to give him any more meds. Patient 3 is sick. He's in the ICU on an inotrope on dobutamine. So you guys caught on to that. He's in the hospital. His blood pressure is borderline. If you actually calculate the GFR for an 89-year-old with a creatinine of 2.2, I think it comes out to like 28. So his GFR also doesn't qualify. So he's too sick, too old, too frail. But patients 1 and 4 are both very reasonable. You can press next for me, Troy. Just have a little animation there. Now, you would see that patient 1, he's not on an ACE and ARB. And so, switching from ACE and ARB over to ARNI is what the recommendation is. I think that fresh therapy is reasonable. You may have a hard time getting that approved from insurance. You may have to put him on something else first. Excuse me. But in terms of the science and the benefit, it's worth a try in him. If you get a rejection from the insurance company, then you can put him on an ARB first, and that'll make your switching over to ARNI easier when the time comes. Okay, great. I think that's right at the end. This is just available for you, and I can see if we can make this. I don't know if they have access to the slides afterwards.
Yeah, slides will be posted on the website in just another hour or two. They will show up.
Okay, great. This is just a chart that I made for myself that shows how I think about things. I think about the classes of medications and then what I'm getting from them: symptom reduction, mortality benefit, potential improvement in LV function, and then which ones are like the add-ons. So which ones I go to afterwards, after I've started the other meds. And then which ones worsen mortality, which is really just inotropes. Those are, of course, just in the hospital or end-stage patients for symptoms. So this is, if it's helpful for you, this is kind of how I organize them in my brain. And so I offer it to you as well. And with that, we'll see if there's any quick 1 or 2 questions before we end.
Excellent. Yeah, thanks, Dr. Toft. Yeah, I realize we're a little bit over time, so thanks everybody for sticking with us. We'll open it up for questions right now. So please feel free to write in through the chat box or unmute yourselves.
Have you seen any issues with decreased kidney function with ARNIs in the people you're prescribing, or not so much?
Yeah, it was definitely there in the trials when they were doing it in the tens of thousands or thousands rather of patients. But in practice, not so much that I'm having to stop or limit it. But I think that's because, again, you start low and go slow, as they say. But thankfully, not people with borderline kidney function, you're always going to have a harder time, right? Because it might tip them over. Good question.
And then with the ARNIs, is there a specific dose that shows greater benefit that you're aiming for, or is it just based on patient and their blood pressure and all those other parameters, or is there something you're working towards?
Yeah, great question. In all of these medications, the goal is on as much as possible. You can look back in the trials and see what was the average dose that people were given, but we believe there to be a class effect, and we call it neurohormonal, meaning it's not the amount, but it's that it's floating around and doing things within the body. So the rule of thumb is maximally tolerated dose. But you have a lot of medicines you have to get these patients on: beta blockers, ARNI, and spironolactone, aldosterone antagonists. And so therefore, sometimes the limit becomes the blood pressure. But yeah, maximally tolerated. Great question. So I will say that I feel personally challenged to work hard to get my patients on ARNI. I think it's easy to